Torque-driven drill dilator to enable Y-configuration biliary stenting for high-grade hilar obstruction. Background. Malignant hilar biliary obstruction often results from cholangiocarcinoma. A multidisciplinary approach is needed and adequate biliary drainage is essential in the management of these cases. The choice between metal and plastic stents is individualized and often center-specific. In patients with limited expected survival, self-expanding metal stents are often preferred to minimize near-term reinterventions. However, for patients anticipated to survive beyond typical stent patency, particularly with the advances of immunotherapy in cholangiocarcinoma, an open-cell dual-sector metallic stent placement using stent-in-stent or Y configuration may be preferred to allow durable suprapapillary and reaccessible drainage. During placement, traversing the mesh of the first stent into the second sector with dilating catheters can be challenging. This case demonstrates successful use of a recently available spiral drill dilator to place a second uncovered stent in Y configuration. A 74-year-old female with newly diagnosed bismuth type 3A cholangiocarcinoma presented for enhanced internal biliary decompression. She had previously undergone percutaneous internal-external biliary drainage of the left hepatic sector by interventional radiology with incomplete resolution of jaundice. She was deemed not to be a candidate for resection or liver transplantation. She was referred to our center for added dual-sector drainage, which was accomplished by ERCP with plastic stenting of the right anterior sector. She was planned for endoscopic dual-sector metallic stent and removal of the percutaneous drain. MRCP with 3D reconstruction video shows the large volume left lobe segments obstructed by a hilar mass, with relatively small volume but separately obstructed right anterior and posterior sector ducts. This is an illustration drawing of malignant hilar biliary obstruction due to bismuth type 3A cholangiocarcinoma. ERCP was performed. Initial endoscopic and scout imaging showed a right-sided plastic stent and a left-sided internal-external biliary drain exiting from the papilla. Both were removed using a snare. After left hepatic and right anterior sector wire access was achieved, the first of two planned 80 by 8 mm uncovered metal stent was deployed into segment 2 in a suprapapillary position. After repositioning a wire through the mesh of the first stent and the stricture into the right anterior sector, attempts to access the right system even with a well-lubricated 4 mm balloon catheter was unsuccessful. A 7 French drill dilator was then inserted over the wire through the mesh of the left hepatic duct stent and the stricture into the right anterior sector. We applied clockwise mechanical rotation to create the tract smoothly without pushback or excessive force, using gentle and controlled torque. This helped in avoiding wire damage, stent dislodgement, or excessive stent deformation. In addition, the drill dilator was advanced under continuous fluoroscopic guidance to ensure proper alignment. After that, a second 60 by 8 mm uncovered metal stent was deployed into the right anterior hepatic duct, forming a stent-in-stent or Y configuration. Cholangiogram confirmed effective dual-sector drainage. Final image demonstrates successful stent-in-stent placement with waste formation at the level of the stricture. The patient felt well after the procedure and bilirubin remained normal. 3 months later, she presented with biliary obstruction and cholangitis. The right hepatic stent was cleared of stones and debris. The same drill dilator was used to enlarge a pathway through the mesh of the right stent into the left lobe for placement of a temporary plastic stent. 6 weeks later, the plastic stent was removed and both sectors were balloon dilated to 6 mm. In conclusion, endoscopic management of malignant hilar biliary obstruction is technically challenging. Our case demonstrates the utility of a newly available spiral drill dilator for enlarging the pathway through the mesh of a single metal stent to place a second metal stent for Y configuration dual sector biliary drainage.